Thank you, Jeff. Thanks again. So, we're going to be talking about red flags and yellow flags, all kinds of flags, this whole 2 days. The idea is that you want to treat the benign problems out of periphery, and you want to get the dangerous ones that can end your life or have serious morbidity and mortality up to the big centers. Once again, still no disclosures. My learning objectives are, I thought I'm going to start with a couple of cases. So I'll show you a few x-rays that I've dealt with in the last couple of months. I want you people, when you look at the history and the pictures, to, in your mind, say, oh, that's a red flag, that's a red flag. And hopefully, by the end of this course, when you see an x-ray like that again, or an MRI, or a certain thing in history, you'll say, well, you know, we discussed this, let's look what needs to be investigated further. And then we're going to look briefly how you approach a patient with back pain and identifying red flags. So if we get to that identifying part, then we'll be lucky. But it's going to be discussed a few more times on this course, so it's more important, these cases. So the first case is Mr. ST. He is 57 years old, he's retired, and he complains of thoracic back pain for more than a year. So when you go through this thing, in your mind, if you think thoracic back pain is a red flag, then keep it in the back of your mind. He's been to various GPs. He even saw a specialist physician, and the x-rays were reported by the radiologist as normal. He was sent for physio for 3 months, and the question now is, you know, at what point do we say, okay, now we should investigate further, do blood investigations, or should we do an MRI scan, or, you know, what's the next step? He's had an x-ray, he's had visits, he's been to physio, he's been to the physician, and the physician actually sent to the physio. In medicine, we've got this amazing thing called the retrospectoscope. It's a wonderful machine that if you know the problem, you can actually look back at the old x-rays and say, there I see the problem, because you know the diagnosis. But when you see the x-ray the first time, often you don't know that. So it's easy for me to look back and say, oh, they missed this, they missed this, missed this, but it's because I know the diagnosis. So, not fair. So, here is the x-ray report from the radiologist. Okay, normal, height, all normal, everything's normal. And then somebody went and did blood tests, and hemoglobin 13, white cells 4, ESR 20, CRP 1.5. Is anybody offended by those blood results or the x-ray report? They're all normal. We agree. Okay. Because it didn't get better, an MRI scan was requested, and generally speaking, if a GP or somebody comes in and says, the person's got back pain, this, then I often say, you know, what does the x-ray show? No, x-ray is normal. And then I say, you know, if you're worried, do some inflammatory markers. Generally speaking, those are normal. Then you continue with conservative treatment. If the ESR is raised or the CRP is raised, then I want to see it urgently, and we'll book an MRI scan. And then, lo and behold, MRI scan comes back, or x-ray comes back, and you can actually see the missing pedicles on the x-rays. Does it reflect? You see there. There at 5 and 6, there's a missing pedicle, 2 on that side, this side 1. MRI scan clearly shows this. Even on lateral, you can see a collapsed vertebra. I did an open biopsy with that a week later. It comes back as metastatic adenocarcinoma. Now, this kind of threw my whole world apart, because for the last 16 years of being a doctor, I knew if you've got a cancer, then your ESR should be raised at least, your CRP should be raised, so think about it. Okay. What are the learning points from this case? So you would have identified amongst yourselves some red flags, and the first thing is that it's not difficult to interpret x-rays. So you should be able to interpret x-rays, basic x-rays yourself. We're all working with back and necks every day. Take some time, look at a few normal x-rays, look at a few pathological ones, look on the internet, go to Google Images, and kind of get, so you must know normal before you try and find abnormal. And then you can, and never read the report first. I always look at the x-ray myself, and then at the end I read the report. Some people are very arrogant, they say, I don't need a report. What does the radiologist know? It's my patient. The point is, often you are so focused on the spine, you don't see the aneurysm in the, right next to the spine. Or you don't see the renal cell tumor in the kidney. So please do read the report. And radiologists cannot walk on water, they also make mistakes. And so you read the report, often they make a mistake, or they can make a mistake, you need to feed that back to them in a nice way. Okay, so thoracic back pain is not common, and if you have pain, then it warrants further attention. Doesn't mean every back pain and thoracic spine needs an MRI scan, but you need to think a little bit more and say, oh, this is not very common. As I said, for this case, I assumed ESR CRP would be raised in the tumour, and clearly this case now demonstrated not every tumour raises your inflammatory markers. And sometimes you get a gut feel or a sixth sense about these things, and something in the history. You listen to a guy talk, you ask him a few questions about his pain at night and things and losing weight, and something that says, you know, I need to go investigate this further, and maybe MRI is now indicated earlier than later. So, second case, Mr. DJ, he's 77 years old. He is thank you. Wasn't part of my presentation. He's 70 years old. He's a German citizen living in Namibia, and he's got a medical aid in Germany. So any medical treatment he gets, he pays cash and he sees a GP. And for 3 months, he's been seeing a GP suddenly with sudden onset back pain, thoracolumbar area, very focal, right at one place. And the GP did an X-ray. Again, the report was normal. He also complained of hematuria. They did an ultrasound of the abdomen, also normal. And he went on and on like this for 3 months. And then at the end, he was referred to a pain specialist. I don't know if you've got pain specialists in this country. We've got a couple of them. And this pain specialist thought it would be a good idea to not request the MRI scan because after all, this guy's paying cash and he's saving money rather than taking the theatre. And clearly the pathology is facet OA and needs a injection to that area, which the patient got, and then was better for 2 days because the local infiltrated the area, and then went back to the local emergency unit with severe pain and hematuria. They did a CT scan, and they found a large destructive lesion involving L1 vertebral body with involvement of the right pedicle, associated with pathological fracture, that is metastasis. Okay, so there are some red flags here all over the place. Okay, and there's your CT scan, and quite clearly see that. And if you go back to the X-rays, you can actually see, if you look carefully, you've got to look carefully, it's not obvious, but there is already on the X-rays, all the X-rays, serial stuff, there are signs of Florka was speaking about a blinking owl and pedicle problems. You know? Okay, so what are the learning points? Sudden onset of focal back pain at advanced age, you know, you've got to think of metastasis. You know, it's got to be back of your head, this could be a cancer and it's spreading. Why would a person who's had no back pain his whole life suddenly have back pain in one spot, and just to say, well, I'm sure it's just old age, facet arthritis. Yeah. Pain specialists, how do I feel about them? Ask me later. So, but know who you're referring to, and these people also need to know what their limitations are. They need to know where they need to refer these patients. Scott and I were discussing yesterday on the bus, I think, just about what the changes happening in the States about these pain specialists, and there's actually almost, don't quote me, but no evidence for facet blocks, rhizotomies, blah, 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 all of these things. The only evidence there is vaguely is for caudal epidural injections for acute radicular symptoms, not back pain. So any other injection is financially good for the doctor, but patient benefit, and the research doesn't show much benefit in the long term. Don't take shortcuts to save money. So don't save the person money by not doing an MRI and then doing expensive injection. The patient needed the MRI, do it. Okay. Third case. Here's a patient that presented slightly earlier, the 80-year-old male. He goes to the rural hospital 8 months ago with urinary retention, gets given a catheter, sent home again. 4 months later, walks in with crutches, because he's got myelopathy, and he's then sent to Windhoek, and their X-rays are reported again, or sorry, seen by the medical officers, and they send him home again. An 80-year-old, 4 months later, ends up in my spinal clinic, MRI comes, and we see high-ducted cyst disease. Took him to theatre, did a decompression, did all those things, and he's recovering well. And the learning points here are that an 80-year-old with urinary retention is not normal. You refer that immediately, it's a no-brainer. An 80-year-old needing crutches to walk is not normal. This should turn on red lights everywhere, but for some reason it doesn't. Okay. Fourth case, Mr. DK, 50-year-old male. He's a lawyer. He's known with previous treated prostate cancer. And if you look here, you see all the little funny little clips in there, so something was done there. Severe back and left leg pain. He cannot walk or stand for the last 6 weeks. He's got maximum painkillers. I'm obviously, this is a lawyer. It's a red flag for me, dealing with a lawyer. So I just say to him, conservative treatment's the best for you. You don't need surgery. He's going to sue me after the surgery. So, how long do I treat conservatively? Do I do an MRI immediately for the severe leg pain? Do I do blood tests? And we did this, and anybody here, except Ian Flock, can tell me what that is? So obviously the patient's very worried it's a cancer, a follow-up cancer. No one can tell me really. Radiologist not sure. Phoned a few colleagues in Africa. What is this? What is this? No one's really sure. Is it in the tube? Is it in the cord? Is it a tumor? What is it? Ended up being a ganglion cyst. So we all learn things every day. Okay. So the learning points are: if you have a previous cancer, you really need to be aggressive with this guy and the patient and work up further. He was on maximum painkillers and. In the end, we drained that, so he started to show the ganglion system, good outcome, resolved, did very well. So waiting another 6 weeks for another for MRI scan, I don't think would be appropriate. Second last case, Mr. M.M. He is seen by his GP, 1 year history of back pain. Unfortunately, the X-ray of the back is actually normal. He's got some right thigh pain, some buttock pain, and he walks with a crutch. He's mobilized with a crutch. And the GP says he's exhausted all the conservative management options with physio, medication, all kinds of things. And the one rule is that back patients generally don't walk with crutches or with a walking stick. So if you see someone with a stick, could be there. Then in the history, I just did the normal stuff that any physio, chiropractor, doctor usually does. You ask them about their medication history. And this GP decided that this guy should be treated daily with oral steroids. So high-dose steroids every day, repeat the prescription for 3 months, again repeated, again repeated, and he's developed avascular necrosis of the hip. This was going there as well. But he basically needs now total hip replacements, both sides, in the next 6 months because of the steroid treatment. So in the history, the fact that he's using steroids is a red flag. Okay. So don't forget the drug history, and it's criminal putting someone on steroids for a whole year and not getting to the source of the problem. Okay. Always screen the hips when you're examining the back. You can get caught out many times the back and hip problems, and patients really need crutches. I think this is the last case. Again, this female we had from Rundu with an accident sitting there with this dislocation, a C7T1 dislocation. And the red flags here would be high energy car accident and complete paralysis. I mean, it's a bit of a no-brainer. Why would you for 2 weeks sit on a person like this and think they might get better? Okay. How am I doing for time? Okay. So I'm going to run through the basics of red flags again. So you've got the primary causes of back pain, muscle strains, ligaments, facets, disc pain, tears, spondylolisthesis, spinal stenosis, and it's easier just to classify according to age, young, middle age, older, certain things happen to certain age groups, malignancies, systemic causes. And how do we evaluate this patient for lower back pain? You need to take a proper history. Where is it? Is it a radicular symptom? Is it a plain back problem? Is it the extreme of ages? Was there trauma? Was there minor trauma, a small fall? Pain at night? And secondary gain issues is a big problem with people wanting compensation or not going to work. Okay, so you can have structural causes in the back itself. You can have other causes, endocrine causes, osteoporosis with aging population. It's easier to treat osteoporosis than to do surgery for them. Okay, sickle cell disease, all other things. There are also causes outside the spine that you must just sometimes think about. Visceral causes, gynae causes, renal cell carcinoma, certain drugs, musculoskeletal problems, hip problems, can all cause back or spinal pain. We're not going to go through the physical examination, but you need to examine them very carefully, do a neurological exam, and every second time when I do consultations with the patient, say, Doctor, you're the first one to examine us properly. It doesn't take a long time. Be systematic, do the same thing every time. It takes 3 minutes, and you can examine the back and pick up something. The patient feels that we touch, they feel that we can give it treatment, so just pick up, don't touch them. Okay. So back pain, we exhaust our conservative management options. If there's persistent pain or there's radicular symptoms, neurology, then we go further. We look for our red flags, we look for our do lab tests, and we do further imaging. So red flags you hear many, many times. Thoracic pain is one of those. Unexplained fever, unexplained weight loss, bladder or bowel dysfunction, history of carcinoma, very young or very old. Those are all red flags for me. Just quickly to x-rays. When should we request x-ray? Does every person that walks in need an x-ray? No, not every person needs that. But generally speaking, you would mild back pain and the protocols that we are being taught here by World Spine Care, and they propose you don't just x-ray every person who walks in with a bit of back pain for 2 days. And after 6 weeks, if there's still persistent back pain, I would consider doing an x-ray. If you suspect infection or malignancy, something serious, then obviously earlier. The problem with my practice is that by the time they come to see me, people have had an X-ray, CT, and an MRI scan. So there's no point in me still waiting another 6 weeks for conservative management. This is an interesting slide in that if you take someone who's under age of 60 years, and he's got no pain, and you do an X-ray, you have to do 2,500 X-rays to find one problem. So a pain-free person under 60, 2,500. So 2,199 you'll do unnecessary X-rays. You'll find nothing. Okay, so that's a very poor yield. Also, if you do an MRI scan of someone under the age of 60 where he's got no pain, 1 in 3 will have a disc bulge somewhere, and 1 in 5 will actually have a herniated disc, but it's asymptomatic. It's just there. So if you MRI too quickly, you put the person into a box, and you make them a victim. You tell them, oh, your back shows a disc, you must have pain, you must be terribly suffering, let's help you. Okay, if you're over 60 and you're pain-free, 1 in 3 people have herniated discs, you've got bulging discs, 80% of patients, and they are surgical, operable things you see on an MRI, people over the age of 60, even if they're pain-free. So be very careful of over-interpreting the MRI scan. I always tell people, the stars have to line up with spinal surgery. You need to get a proper history, and the symptoms must fit in with your examination, with your imaging. If all 3 are not lined up, you mustn't operate that person. And you must exhaust conservative options. Further, after we've done imaging, sometimes some lab tests are useful, inflammatory markers, calcium, alkaline phosphatase, protein electrophoresis, Benz-Jones proteins help us get to a diagnosis. So, last 2 slides. So the key points about back pain is 90% mechanical and will resolve within 6 weeks to 6 months. We heard that everybody here will develop back pain somewhere in their lives. You must pursue diagnostic workup. If you pick up a red flag in history or in your examination, if your ESR is elevated, until yesterday, if ESR was elevated, then I thought it was a tumor. Now I know ESR was normal, it could also be a tumor. And then older people came with minor falls, compression fractures, and tumors. Bed rest is not the best thing for back pain. Okay, those days, and I still see it happens often in Namibia, people have back pain and they get sent home for 2 weeks, lie in bed, dose them with Valium, 10 milligrams BD, and you must sleep it out. That's the worst thing you can do. You need to control the pain and then get them back to normal activity. Okay. Back exercise in the acute phase of pain is not ideal, but it will help to prevent future recurrences and to treat chronic pain. And surgery is appropriate for a really small 1 to 2% of people with back pain. Thank you very much.